I'm a medical doctor and a PhD student at the Danish Epilepsy Center. And today I will present a paper we did on defining the phenotypic spectrum of SLC6A1 mutations. And this was a paper that came out, actually it came online last year, and somehow it made it to the cover of Epilepsia with this very nice figure, but I don't know if that's because they ran out of other nice pictures to put on the front cover. So anyways, so SLC6A1 is a gene that encodes this GABA transporter, a voltage-dependent GABA transporter called GAD1. And GABA is, as you might know, the primary inhibitory neurotransmitter of the human brain. And GAD1 is one of the major GABA transporters in the human CNS. So these GAD1 are expressed at the nerve terminals of the GABAergic interneurons, as well as on astrocytes, and they are crucial for the reuptake of the GABA from the synapse, and thus they are responsible for the extracellular clearing of GABA. These transporters can be found both in the neocortex as well as the cerebellum. And here on the right, you see like what happens if the GAD1 is blocked, which you can also do by using the drug tiagabine. So there has been made mice who are GAD1 deficient, and they have these spontaneous spike wave discharges, and also they have seizures in the form of atypical absences. And you can measure increased GABA levels in these mice. Furthermore, they display some motor disturbances, and they also have stereotypic behavior. So before we did our study, there was a few patients described. Rauch et al. In 2012 reported one patient, and Sanders et al. Also in 2012 also reported one patient. The first one had MAE, which is myoclonic atonic epilepsy, and the second one only had like an autism spectrum disorders. That patient also displayed some absence seizures. Later, 3 more patients were described, also with some epilepsy EEG abnormalities, and they had microdeletions, which included SLC6A1. And then in 2016, one more patient was described who had epileptic encephalopathy. So not many patients described up until that point. Then in 2015, Carville et al., which was a study that we were also part of, did targeted resequencing in 569 people with epileptic encephalopathy. And they found 4 SLC6A1 mutations, and they all displayed this very homogenic phenotype with myoclonic, atonic, or atonic seizures in early childhood, as well as these generalized spike wave or polyspike wave discharges. And in this very large cohort, 85 individuals had a diagnosis of myoclonic atonic epilepsy. So it seems like SLC6A1 is enriched in these MAE patients, where almost 5% have this mutation. And so they set out to validate it in another cohort, where they found an additional 2 MAE patients with an SLC6A1 mutation. So it seems that about 4% of MAE patients have mutations in SLC6A1. Furthermore, in the Kappel paper, some atypical features were noted. The patients had preceding developmental delay, thus they had developmental delay before the onset of epilepsy. And then they showed slowing or regression in half of them after epilepsy onset. Almost all of them had autistic features, and some of them had tremor. One of them also had an ataxic phenotype, and one had these hand stereotypies. So they showed like some of the things that were also seen in the GAT1 deficient mouse. Only 3 of the individuals had generalized tonic-clonic seizures, so this seemed to be quite rare. And they found that 7 out of 8 were female, but it was a small cohort, so they thought that it was probably a reflection of that and not a real gender issue. So just a few words on myoclonic atonic epilepsy. So according to the ILAE, the definition of myoclonic atonic epilepsy is normal development before epilepsy onset and absence of structural brain abnormalities. But so far they should develop normally until the onset of the epilepsy. And then like quite a large range of onset of the epilepsy, which should be with myoclonic, atonic, or atonic seizures. And then they, on the EEG, they should display these 2 to 3 Hertz generalized spike and polyspikes and slow waves. And then there are some diagnoses that should be excluded before you can like make the diagnosis of myoclonic atonic epilepsy. And so far, several other genes have been found to be responsible for MAE, such as SLC2A1, GABA2, and CHD2. And now this SLC6A1. So we aimed with our study to like do a better characterization of the patients with SLC6A1 mutation, both like on their EEG as well as the clinical presentation. So we collected these patients with presumed pathogenic mutations in SLC6A1 through our through an international collaboration with epilepsy genetic centers worldwide. And this cohort consisted of patients with intellectual disability or childhood epilepsies, where there was not previously identified a genetic cause. And we collected information on the clinical picture of the patients, as well as the neurophysiology, imaging, and genetics, of course. We had all the EEGs reviewed by only one epileptologist, my colleague Elena Gardella, to be sure that there was that we had the most valid evaluation of these EEGs. And furthermore, regarding the mutations, we classified variants as pathogenic if they were non-synonymous, splice site altering, or truncating, not seen in healthy controls, and predicted damaging and either were de novo in the patient or came from an affected parent. The seizures were classified according to ILAE classification. So atypical absences were defined as absence seizures with like these additional clinical features such as myoclonic jerks, for example, and with this EEG pattern of diffuse spike wave less than 3, with like a slower onset and offset compared to the typical absences. And patients with this like a picture, electroclinical picture, suggesting a generalized epilepsy that resembles myoclonic atonic epilepsy, but not really fulfilling all the diagnostic criteria, were classified as MAE-like because they were so close to the MAE phenotype. So what we found was we were able to collect 27 unpublished patients with SLC6A1 mutations, and this was 21 probands, plus they had 6 affected family members. Furthermore, we took 4 of the previously published cases and included them for like only EEG characterization. So in total, we studied 31 patients. And the gender ratio was 18 females and 13 males, so not really a significant skewing there. So the female overload from the Carville paper was probably due to like small cohort or something. Then we looked at the genetics. We found 17 mutations that were de novo, and then 2 mutations that segregated dominantly in the families that you see here on the right. And then we had 2 mutations where we could not do the segregation analysis, but they were both recurrent, and so we classified them as pathogenic. Yeah. So regarding the types of mutations, we found 14 missense mutations that all affected these highly conserved nucleotides. Then we found 2 splice site mutations, 1 frame shift, 3 nonsense, and 1 in-frame deletion. So this, like all these, suggest a loss of function as the most likely disease mechanism. And this has also been seen previously, that several mutations are a loss of function per se, like the truncations and frame shifts and microdeletions. But then there has also been functional studies in the arginine 44 and the alanine 288 mutations, and they both showed significant decreases in the GABA transport activity, up to as much as 98%. So definitely loss of function. And what happens is that when there's this loss of function, then there's an increased synaptic GABA level, and this has been shown to enhance like the inhibition and then lead on to the appearance of spike wave discharges, which is thought to be like the mechanism behind why these mutations can cause epilepsy. And also, as I mentioned in the beginning, if you give the tiagabine, which is like an anti-epileptic drug that blocks GAD1, it can actually cause both myoclonic seizures and also absence status epilepticus in humans. So that supports this theory of why loss of function in these transporters can lead to epilepsy. Then we also saw that there was some recurrent mutations, suggesting that there are some hotspots in this gene, especially the 288 and the 342 positions were quite prevalent in the total cohort and overall. Then we went on to look at the cognitive development. And this is what it looks like before epilepsy onset. Just to let you know that we only had this data available for 20 patients. But as you can see, only 20% are like have normal development before epilepsy onset. The majority, like half of them, have mild intellectual disability. But there are even like one that has a severe intellectual disability. And then after epilepsy onset, there is a deterioration. So then only 4 patients have normal intellect, but the moderate intellectual disability grows quite to 36%. So we saw that after epilepsy onset, cognition deteriorated in 35% of the patients. One of the most common features was language delay in these patients, and we could not find like a correlation between how well their seizures were controlled and how well they did cognitively. We also found that some of the patients displayed other features such as aggressive behavior, attention deficit disorders, these stereotypies, automatisms, as well as like true autistic features. Yeah. When evaluated neurologically, we found that like in almost 1/4, we found mild ataxia or like an unsteady gait, as this was the most prevalent feature. And then some had hypotonia, some had like an impairment of their fine motor skills, and some had a tremor. We couldn't find like any dysmorphisms or malformations in these patients. Then we looked at like their epilepsy phenotype, and 28 out of 31 individuals had epilepsy. Their mean age at seizure onset was 3.7 years, but again with quite a large range from like 6 months to 7 years. We didn't have that long a follow-up. Longest follow-up was 21 years, but the mean age at follow-up was 11. They had quite a lot of seizure types, but quite a lot had absences where there was no specifications to the absences. And then there was, in 10 patients, it was defined as atypical absences. And in as much as 14 patients, like half the patients had atonic seizures. 10 patients had myoclonic or myoclonic atonic seizures. And only 5 had generalized tonic-clonic seizures. So then we tried to look like, could we look at the epilepsy syndrome? And we found that in 16 they have these MAE features, but didn't quite fit the definition. And then 4 had like a real MAE diagnosis according to the criteria. Then there was just a few with Lennox-Gastaut or early onset absence epilepsy, childhood absence epilepsy, and 2 had this focal epilepsy. Quite a lot became seizure-free, 18 out of 28, and interestingly, 10 of them became seizure-free with valproic acid, either as monotherapy or in combination. And 8 became seizure-free with other anti-epileptic drugs. Furthermore, 4 patients achieved like not seizure freedom, but partial seizure control, also with valproate. And we looked a little bit into this, and it seems that valproate is thought to have a positive effect on the GABA system, which could be part of the explanation why there seems to be this favorable response to this to valproate. But we can't really explain it like totally on the functional level. None of our patients tried ketogenic diet, which there has been I think a case report that said that the patient had a very excellent response to ketogenic diet, but none of our patients tried it. Then there was these 3 patients or subjects that never had epileptic seizures, but only had learning disabilities or a very mild ID with or without autistic features, which this has not been described in SLC6A1 before. So that was quite interesting. And in 2 of these 3 subjects, there was a relative that had a true MAE or an MAE-like phenotype. So a relative that had seizures. So this suggests that there's a variable expressivity of this phenotype, which we don't know why, but it could be due to genetic or environmental modifying factors. Then as I said, my colleague Elena Gardella reviewed the EEGs, which were available in 27 patients. They were all abnormal. They showed, in 11, they showed a slowing of the background. And in 25, they showed 25 out of 27, so almost all of them. They showed these bursts of irregular generalized spikes and polyspikes and slow waves with a gradual onset, especially in the occipital regions. And they correlated with those discharges. They correlated with the seizures of the patients. And this is 3 patients displaying these distinct electro discharges. So in 2 patients, there was a sort of a typical course of their epilepsy, where they initially presented with this MAE-like phenotype with irregular generalized spikes and slow waves, and then they transitioned to this a focal epileptiform abnormalities around school age in these patients, and they were enhanced by sleep, like it happens in ESIS, for example. However, the patients did not display the deterioration that are usually seen in ESIS patients. So they were on the same cognitive level as before. This ESIS-like EEG changes occurred. So that was, quite peculiar. Regarding MRI, most cases were unremarkable, nothing, they were normal. And then 5 had these non-specific abnormalities, such as Vermean hypoplasia or enlarged frontal spaces and such. So nothing much there to do. So in conclusion, we believe that these SLC6A1 mutations cause a specific epilepsy syndrome. We like to call it MAE with a twist. So it's MAE, but occurring in the context of an abnormal early development. The most common seizure type is absence seizures. They have mild to moderate intellectual disability with especially language delay, and this will precede the epilepsy onset. The electroclinical features of the SLC6A1 related epilepsy are variable and can change, as I just described in the 2 a little bit peculiar patients. So the contribution of epilepsy to the cognitive impairment in these subjects with SLC6A1 mutations is like a little bit uncertain at the moment, because we don't know what comes first. Yeah, and then I just want to say thank you to everybody who contributed to the paper. And it's just a small advertisement that in June we will be having this symposium in Denmark, and it's all about epileptic channelopathies, and you're all welcome if you want to come. Thank you.